A firm tender non-reducible lump in the inner upper port of the femoral triangle is illustrated here, overlays the saphenous opening, just below and lateral to the pubic tubercle, which marks the site of exit from the femoral canal, medial to the femoral vein. Such a swelling will be either a strangulated and obstructed femoral hernia, which now exhibits the classic signs of strangulation, being tense, tender, with no cough impulse, and irreducible. A lymph node swelling of the femoral lymph node group, which drain the lower limb. Perineum, vulva or anal canal, in males penis and scrotum replace vulva as primary foci. The most likely of these diagnoses in an adult female, and the most important to diagnose quickly, is a strangulated femoral hernia. B is correct. Femoral hernias are more common in women than men, and their oblique course, via femoral septum to femoral canal, then through the cribriform fascia at the apex of the canal into subcutaneous fat, makes them more prone to strangulation of their contents than a strangulated inguinal hernia, which emerges from the superficial inguinal ring just above and medial to the pubic tubercle. If the ischemic contents are intestine, bowel obstruction with cramping, abdominal colicky pain, abdominal distension, constipation and vomiting may be associated features and should help cue the diagnosis. If the contents are omentum, such additional clues are absent, and systemic manifestations are confined to fever and general toxemia. The major differential diagnosis is of a femoral lymph node swelling, which may be secondary to an infective or neoplastic primary focus or may be a primary lymphoma. Differentiation requires meticulous examination of potential primary sites, which may be occult, not forgetting regions such as between the toes, in the anal canal, beneath the foreskin, and in the vulva. Lymphoma assessment requires examination of all other lymph node areas as well as checking for liver and splenic enlargement.